All right, welcome everyone. I want you to picture this. You're on the wards, you've got a patient with type 2 diabetes, and their A1C is still high, even though they're already on metformin. So, what's your next move? In this explainer, we're going to build the exact framework you need to answer that question, not just for your exams, but for your patients. Let's dive right in. So, here's our game plan. We're going to build this out step by step. We'll start with the big picture philosophy, we'll lock down the first line therapy, and then we'll get into the really interesting stuff, the nuanced clinical decisions you'll be making every single day.
Okay, let's start with a really crucial shift in mindset. Because in modern diabetes care, we are moving way beyond just chasing that A1C number.
And this really gets to the heart of the matter. Type 2 diabetes isn't just a pancreas problem, right? It's a systemic disease. You've got the liver just pumping out way too much glucose. You have muscle and fat cells that are resistant to insulin. The kidneys are actually reabsorbing too much sugar. And of course, the beta cells are failing. The whole point of modern therapy is to target these specific underlying problems in the disease process. So, with that whole complex picture in mind, where on earth do we begin treatment? Well, in almost every single case, we start with the anchor, the foundation, metformin. Here is your high-yield rundown on metformin. Its main gig is to tell the liver, hey, calm down with the glucose production. It works well, it's weight neutral, and it's cheap. Now, the single most important clinical pearl to get your patients to actually take it is this: start low and go slow. Seriously, begin with 500 milligrams with their evening meal to keep those GI side effects at a minimum. And never forget the absolute contraindication. You do not use it if their eGFR is less than 30, period. And here it is. This is the question you will face constantly. On the wards, in your clinics, your patient is doing the lifestyle stuff, they're taking their metformin, but that A1C is just not where you want it to be. So, what's next? Well, the answer is not just picking another drug out of a hat. So, how do we decide on that critical second medication? This brings us to the modern clinical decision framework, and it's all about looking at the whole patient, not just their lab values. This flowchart right here is the absolute core of our decision making. Now look closely. Notice that very first question. Before we even think about the A1C, we ask, does this patient have high-risk comorbidities? We're talking about established cardiovascular disease, heart failure, or chronic kidney disease. If the answer is yes, that dictates our very next choice, and it's often independent of the A1C target. So let's follow that high-risk path first, because this is where our choice of drug is driven by something much bigger than glucose control. We're talking about life-saving organ protection. For your patients with heart failure or chronic kidney disease, the SGLT2 inhibitors, you'll know them as the Flozins, are an absolute game changer. How do they work? Well, they block glucose from being reabsorbed in the kidney, so patients literally pee out the extra sugar. But their real superpower is what we call the cardiorenal shield. They have been proven to reduce hospitalizations for heart failure and dramatically slow down the progression of kidney disease. One key risk to be aware of, it's rare but serious, is something called euglycemic DKA, where ketoacidosis happens even with normal blood sugar. Okay, now what about your patient with a known history of atherosclerotic cardiovascular disease, like a prior heart attack or stroke? Here, a GLP-1 receptor agonist is a phenomenal choice. These things are metabolic powerhouses. They boost insulin secretion, they slow down the stomach so people feel full longer, and they lead to significant weight loss. And, most importantly, they have proven cardiovascular benefits, reducing the risk of a future stroke or heart attack. Okay, let's back up. What about all the patients who don't have those major high-risk conditions? For this group, our decision-making pivots. We start to prioritize other really important patient-specific needs. So, in this pathway, we start asking a completely different set of questions. We ask, what's most important for this person sitting in front of me? Is avoiding low blood sugar, hypoglycemia, our top priority? Maybe in an older patient? Is weight loss a major goal for them? Or, and this is a big one, is cost the primary barrier to them getting the care they need? So let's say your number one goal is minimizing the risk of hypoglycemia. The DPP-4 inhibitors, or the gliptins, are a fantastic choice. They're pills, they're weight neutral, and they are incredibly well tolerated. This makes them almost perfect for older, more frail patients where a low blood sugar event could be catastrophic. Now, they're not the most powerful drugs, but their safety profile is really their key selling point. Finally, we have to talk about cost. When cost is the main driver, sulfonylureas are still part of the conversation. They are very effective at lowering blood sugar, and they are dirt cheap. But, and this is a huge but, this comes with a major trade-off. They work by forcing the pancreas to pump out insulin no matter what the blood sugar is. And that means they carry a high risk of hypoglycemia and almost always cause some weight gain. This is a critical conversation to have with your patients.
Okay, so that was a whirlwind tour of the modern diabetes pharmacy. How do we pull all this together into a practical tool that you can actually use day in and day out when you're on the wards? This has to be your guiding principle. If you remember one thing from this entire explainer, make it this. Modern diabetes care is all about personalized medicine. It's about looking at the human being in front of you, their other medical problems, their goals, their fears, their risks, and tailoring the therapies specifically to them. And this table right here, this is that principle in action. This is your high-yield cheat sheet designed to live in your white coat pocket. You can see it all at a glance. Look at metformin. It's the foundation, no risk of lows, weight neutral. Now compare that to a sulfonylurea. Great on cost, but high risk of lows and weight gain. Or the GLP-1s, awesome for heart disease and weight loss. No risk of lows, but you have to watch for nausea. This is your tool for making smart, evidence-based, patient-centered decisions right at the bedside. So I'm going to leave you with this question to think about. As you step onto the floors for the very first time, with this framework in your head, how are you going to make that critical shift? How are you going to stop just treating a number and start truly treating the complex, unique patient sitting right in front of you? That's the challenge, and honestly, it's the most rewarding part of the job. Good luck out there.